Thank you, Ajay. Good morning, everyone. Of course, today of all days is the day I cut myself shaving. So hopefully, hopefully we make it through okay. But it's a pleasure to be speaking with you about a topic that's near and dear to my heart, acute kidney injury. AKI is the #1 reason why nephrologists are consulted among inpatients. It's a topic that every general internal medicine person needs to know something about. Occurs very commonly, especially in hospitalized patients. And sometimes it's fairly straightforward, but other times the diagnostic workup is more challenging. So let's jump right into it. I have no disclosures. Here's an outline of the talk. So we're going to briefly discuss the nomenclature and definitions of acute kidney injury. We will talk about the epidemiology and physiologic classification. We will go through the diagnostic approach, and we'll talk about a couple of recent randomized controlled trials that have been published, and then we'll end with a couple board-style questions. So as many of you know, AKI was previously known as acute renal failure. And over a decade ago, the nomenclature changed to acute kidney injury. Of course, acute refers to occurring within hours to days. Kidney is more familiar to patients than renal. And there has been a general trend in nephrology toward using kidney instead of renal. For example, end-stage kidney disease instead of end-stage renal disease. And injury refers to organ damage as opposed to failure, which implies the need for dialysis, which is only required in a minority of patients with AKI. Now, historically, AKI was defined by various consensus criteria. There was the Rifle criteria, which many of you may be familiar with. That was from 2004. And then there was the Akin criteria, which was slightly modified in 2007. The current definition that we use is from 2012, and it's known as the KDIGO definition. And it consists of any of the following: an increase in serum creatinine of at least 0.3 in 48 hours, or at least 50% in 7 days, oliguria, less than half an ml per kg per hour for 6 hours, or need for dialysis. Now we can further talk about stages of AKI, stage 1, 2, and 3. There's even stage 1A and 1B that have been proposed. There's stages based on creatinine versus urine output. But you'll notice I put an X through this. I really don't want you to focus on this. And my mentor, Sus Weicker, I think really put it best in a recent editorial in Kidney International when he said, on rounds, when a medical student presents a case of AKI, the focus may turn to the KDIGO sanctioned stage. Is it 1A or is it 1B? Or could it even be stage 2? We then have less time to argue over why the creatinine is increased in the first place. So I think this is really important that we focus on the pathophysiology and not so much on the stage. The staging is useful from an epidemiologic standpoint and for research, but not so much clinically. Now, just briefly about the epidemiology. AKI occurs in roughly 10% of hospitalized patients and in up to half of ICU patients. It costs more than $10 billion annually in the US alone. And patients who develop AKI are at greatly increased risk of in-hospital death. Those who survive have an increased risk of chronic kidney disease, end-stage renal disease, and cardiovascular events. And no therapy reliably prevents or treats AKI, with several notable exceptions, which we will discuss. When we talk about etiologies of AKI, there's a physiologic classification, which we will discuss, and then there are common clinical settings where AKI occurs. And both are important to think about. The physiologic classification includes pre-renal, intrinsic renal, and post-renal causes, and is really focused on where in the kidney, or is it before or after the kidney, that the injury is occurring. Whereas on the right side, you see the common settings where AKI occurs. And this includes cardiac surgery, sepsis, exogenous nephrotoxins such as chemotherapy, antibiotics, NSAIDs, and IV contrast, and endogenous nephrotoxins, including myoglobin from rhabdomyolysis, hemoglobin from microangiopathic hemolytic anemia, and phosphate and uric acid from tumor lysis syndrome. And this is, of course, not an exhaustive list, but these are some of the more common causes. Now, I'm sure many of you remember learning in medical school about pre-renal, intrinsic renal, post-renal. Whether you're a medical student, resident, fellow, or nephrology attending, this remains a useful classification in terms of approaching a patient with AKI. Pre-renal azotemia is when the serum creatinine increases due to renal hypoperfusion. There is no structural injury to the kidney. Restoration of hemodynamics leads to rapid recovery. And restoration of hemodynamics could be through IV fluids or other interventions. Causes of pre-renal azotemia include volume depletion, such as GI loss or hemorrhage, decreased effective arterial blood volume, which can be seen in CHF, cirrhosis, or hepatorenal syndrome, and impaired renal hemodynamics, which can be seen with NSAIDs, ACE inhibitors, or ARBs. And the diagram on the right shows how NSAIDs and ACE ARBs can exacerbate a volume depleted state. So when you are volume depleted, let's say from diarrhea, you have increased vasodilatory prostaglandins, which act on the afferent arteriole here to vasodilate and maintain perfusion to the glomerulus. NSAIDs counteract the vasodilatory prostaglandins and result in afferent arteriolar vasoconstriction and therefore impaired perfusion to the glomerulus. On the other side, on the efferent side, when we're volume depleted, the other thing that happens is we have increased angiotensin II, which causes efferent arteriolar vasoconstriction to again maintain hydrostatic pressure to the glomerulus. ACEs and ARBs, of course, counteract angiotensin II, resulting in efferent vasodilation. Now, in the chronic setting, that's a good thing. That's why ACEs and ARBs are first-line therapy for chronic kidney disease. We want to have reduced hydrostatic pressure to the glomerulus because over time, it's bad to have high hydrostatic pressure. But in the acute setting, when you're volume depleted, we don't want this to happen. And this is why we often tell our patients who are on ACEs and ARBs, if you get sick, if you're febrile, if you're not eating, if you have diarrhea, don't take your ACE and ARB. It's okay if you miss it for a few days, but because ACEs and ARBs can exacerbate a volume depleted state. Okay, what about intrinsic renal disease? When we think about intrinsic renal disease, we think about different parts of the nephron or the kidney that are injured. And this includes the small vessels, the tubules, the large vessels, and the interstitium. Now, when we're thinking about acute kidney injury occurring in the hospital, usually we're talking about tubular injury. This is the most common form of injury. And tubular injury can come in two flavors. We can have ATN or we can have obstruction. ATN, or acute tubular necrosis, can occur from ischemia. For example, if there's a rapid drop in blood pressure, or if a patient is requiring vasopressors, or it can occur due to endogenous toxins, again, such as rhabdomyolysis or hemolysis, or exogenous toxins, such as contrast, cisplatin, aminoglycosides. On the other side is tubular obstruction, which can occur when proteins crystallize in the tubular lumen. And this can occur with, for example, light chains from multiple myeloma, uric acid from tumor lysis syndrome, various drugs such as methotrexate or acyclovir. Interstitial disease is most commonly acute interstitial nephritis, which can be seen with antibiotics and other medications. There are also autoimmune syndromes such as Sjogren's, which can also cause interstitial disease. In terms of large vessels, renal vein thrombosis is something to think about in patients who are hypercoagulable. For example, patients with nephrotic syndrome. Abdominal compartment syndrome is a frequently missed cause of AKI in ICU patients, particularly in trauma settings where patients get massive amounts of IV fluids and where there's intra-abdominal pathology. And this can be detected by an elevated bladder pressure, typically a bladder pressure above 20. And then, of course, there's injury to the small vessels, which can include glomerulonephritis, conditions such as TTP or DIC. Okay, and then there's post-renal injury, which is essentially a plumbing problem. The diagnostic workup to rule out post-renal is fairly straightforward. The first step is to just check a bladder scan or to insert a Foley catheter to make sure that there's no obstruction at the level of the urethra or at the opening of the bladder. You can also check a renal ultrasound or a CT abdomen pelvis, and that will, of course, tell you if there's obstruction anywhere along the urinary tract. A couple pearls here. A renal ultrasound is not needed in every patient with AKI. The utility is heavily dependent on pretest probability. So if you have a patient who clearly you have an alternative explanation for the AKI, they're in the ICU on 3 pressors, they don't necessarily need a renal ultrasound. On the other hand, if you have a woman coming into the ER with a history of ovarian cancer, who all of a sudden has an unexplained elevated creatinine, that is the patient that needs imaging to rule out obstruction. The other pearl is that early in the course of obstruction, you can have a false negative on imaging. And that's, of course, because it takes time for hydronephrosis to manifest on imaging. Studies to consider ordering. So this depends heavily on the clinical context. Again, not every patient needs every test. Urine tests include the urinalysis, and that's where you take a dipstick, and the urine sediment is where you actually look at the urine under a microscope, and the FeNA, the fractional excretion of sodium. And we'll talk about each of these briefly. Blood tests include the Chem7, calcium, phosphate, uric acid, CPK, SPEP, serum free light chains, CBC with DIF, mainly to look for eosinophilia. So we used to look for eosinophils in the urine for acute interstitial nephritis. That is no longer a recommended test. It has not shown to be useful. Eosinophils in the blood, however, peripheral eosinophilia, can still be useful for AIN. ANCA, anti-GBM, ANA, C3, C4, cryo. These are tests you would order if you're suspecting glomerulonephritis. For example, if the patient is presenting with a lot of hematuria and proteinuria. LDH and haptoglobin if you're suspecting hemolysis. And of course, we discussed renal ultrasound or CT if you're concerned about obstruction. So the urinalysis in AKI. So I just wanted to go over a couple pearls. If you see blood, which is really heme, on a urinalysis, but no RBCs on the sediment, then you should be thinking about rhabdomyolysis or hemolysis, because the urine dipstick really is just detecting heme. So if there's heme present, but there's no intact red blood cells, then the only possible explanation is that it's coming from myoglobin or from free hemoglobin. Normal glycemic glucosuria, you should be thinking about proximal tubular dysfunction, also known as Fanconi syndrome. So this is where the serum glucose is less than 180, but you have 2+ or 3+ glucose in the urine. The only way that can really occur is if there's proximal tubular dysfunction, if the proximal tubules are not reabsorbing glucose. If the serum glucose is above 180, then pretty much everyone is going to have some glucose in the urine. You can't really interpret that. But if your glucose is less than 180, you really should not have glucose in the urine. And proximal tubular dysfunction can occur with various drugs like tenofovir, ifosfamide, and cisplatin, or it can occur due to paraprotein disease from multiple myeloma, for example. Okay, now here are a few specific urinalysis, urine sediment findings, and some diagnoses that go along with them that you should be thinking about. We already talked about the first one. So let's say you have 3+ hematuria on dipstick, but a negative or only trace RBCs on urine sediment, you should be thinking about rhabdo or intravascular hemolysis. If you see a lot of proteinuria, red blood cells and white blood cells, you should be thinking about glomerulonephritis. A bland urine sediment can be seen with prerenal azotemia, cardiorenal syndrome, hepatorenal syndrome, or contrast nephropathy. Muddy brown casts, you should be thinking about ATN. Sterile pyuria, so if you have a lot of white blood cells in the urine, but there's no bacteria, you should be thinking about AIN. And oxalate crystals, think about ethylene glycol toxicity. the fractional excretion of sodium, or the FeNO. So the FeNO is the percentage of filtered sodium that is excreted. It can be easily calculated as the urine sodium times the serum creatinine over the serum sodium times the urine creatinine. Now, the traditional teaching is that if you have a FeNO less than 1%, you're pre-renal. And if you have a FeNO above 2%, you have ATN. And if it's between 1 and 2%, it's not terribly useful. Now, a low FeNO does not necessarily mean to give IV fluids. There are multiple things that can cause a low FeNO that do not necessarily mean that your volume depleted. And these are listed here. Glomerulonephritis, rhabdomyolysis, and contrast can all cause a low FeNO. Rhabdo and contrast can cause a low FeNO because they cause afferent arteriolar vasoconstriction. So the kidneys think that they are in a pre-renal state. And glomerulonephritis can cause a low FeNO because it's associated with high levels of renin and angiotensin, and therefore avid sodium reabsorption. So you need to be aware of these sort of misleading causes of a low FeNO. Causes of a high FeNO include diuretics and CKD. So the take-home message here is it's okay to use the FeNO, but you do need to be aware of some of these caveats. AKI prevention and treatment. So I said before that AKI doesn't have any way of preventing it or treating it, but that there are various specific examples where we actually do have treatment or prevention. So in rhabdomyolysis, the treatment is IV fluid, or I should say prevention. So this is really, patient comes in with rhabdo and you're trying to prevent AKI. You want to give them aggressive IV fluids and possibly urinary alkalinization. I say possibly because it's largely fallen out of favor, although sometimes we still do it. But the clinical pearl here is if you are going to alkalinize the urine by administering sodium bicarbonate, you do need to watch out for low ionized calcium and low potassium. Tumor lysis syndrome, the treatment is, again, IV fluids and rasburicase to take care of the elevated uric acid. Now, clinical pearl here is that AKI itself will raise the serum uric acid level. And so not every patient with AKI and a slightly elevated uric acid level needs rasburicase. I feel like at my hospital, we use it way too often. The patient really needs to have evidence of tumor lysis syndrome. So they need to have other labs that go along with it. First of all, they need to have cancer, and usually it's a liquid cancer. They need to have an elevated LDH, usually elevated phosphate, et cetera. CHF, the treatment is a loop diuretic. And the pearl here is that a mild increase in serum creatinine does not always mean that you need to back off diuresing. In fact, there have been several epidemiologic studies that have shown that small increases in serum creatinine in the setting of diuretics actually associates with improved outcomes. And that's because the patients are being effectively diuresed. To some extent, the creatinine will go up slightly with diuresis just as a result of the hemoconcentration. Acute interstitial nephritis, the treatment is to discontinue the offending agent and steroids. And the pearl here is that fewer than 10% have the classic triad of fever, rash, and eosinophilia. So the absence of the triad certainly should not rule out AIN. Frequently, patients will just have one of these things or even none of them. Anti-GBM disease, the treatment is plasmapheresis, Cytoxan, and steroids. And the pearl here is that pulmonary involvement, interestingly, is rare unless there is underlying lung disease. For example, if the patient is a smoker or if they have COPD. Just briefly, indications for dialysis in AKI, AEIOU, acidosis, electrolytes. And when we talk about electrolytes, we're mainly talking about hyperkalemia. Toxic ingestions, volume overload, and uremia. And uremia, classically, we're talking about altered mental status. Occasionally, we may be referring to uremic pericarditis and other uremic manifestations that we used to see decades ago when people had BUNs of 300, like uremic frost. We don't really see that as much anymore. So we're mainly talking about altered mental status. Just briefly, dialysis modality in AKI. So indications for continuous renal replacement therapy as opposed to intermittent hemodialysis. So hemodynamic instability, for example, if a patient is on multi-pressor shock, you're probably going to want to put them on a continuous form of renal replacement therapy, which is more gentle in terms of hemodynamically. Large daily obligate fluid intake, traumatic brain injury or concern for herniation. And the concern here is that on intermittent hemodialysis, you have much more rapid shifts of electrolytes, which could worsen herniation, and hepatic failure. Okay, I would like to talk about two large randomized controlled trials that were recently published, the PRESERVE trial and the SMART trial. These were both published in the last couple of years. So the PRESERVE trial took more than 5,000 patients undergoing coronary or non-coronary angiography, and they randomly assigned them in a 2x2 factorial design to IV bicarbonate versus IV saline and N-acetylcysteine versus placebo. And these interventions were started prior to coronary angiography or non-coronary angiography. So there ended up being 4 groups total. The primary endpoint was a composite of death, dialysis, or persistent increase in creatinine at 90 days. And the findings were that there was no effect of either intervention on the primary outcome. So there's no reason to give bicarb to patients to prevent contrast nephropathy. We do still tend to want to avoid volume depletion in these patients. So it is reasonable to give IV fluid prior to undergoing contrast exposure, particularly if you think the patient is dry. The SMART trial took more than 15,000 critically ill patients, and this was a pragmatic cluster randomization. So not a single patient signed a consent form. This was because it was a pragmatic trial, all done at Vanderbilt. Patients were randomly assigned to normal saline versus balanced crystalloid, for example, lactated ringers. The primary endpoint was similar to the previous trial, composite of death, dialysis, or persistent increase in serum creatinine over 200% at discharge or 30 days. And here, the findings actually were that there was a lower incidence of the primary endpoint in the balanced crystalloid group. So it was a small difference. It was about a 1% difference, but with 15,000 patients, it was statistically significant. So if you have a question on the boards about which is the preferred fluid management strategy in an ICU patient, the answer would be balanced crystalloid. Okay, we're going to do a couple questions and then we'll conclude. So the first question is, a 70-year-old man with metastatic melanoma presents to oncology clinic complaining of non-bloody diarrhea and is found to have a serum creatinine of 6.5, up from his baseline of 1.2. He says he's been staying well hydrated by drinking Gatorade. He has been receiving treatment with ipilimumab, and his most recent treatment was 3 weeks ago. Urine protein creatinine ratio is 0.5, and renal ultrasound is negative for obstruction. Which of the following is most likely to be seen on renal biopsy? Collapsing FSGS, thrombotic microangiopathy, acute tubular interstitial nephritis, ATN, or glomerulonephritis with crescents. We'll go to the next slide. So most people said ATN, interesting. So the correct answer was C, acute tubular interstitial nephritis. I'm sure most of you, if not all of you, have heard about the immune checkpoint inhibitors. You've probably treated patients who have had side effects from immune checkpoint inhibitors. Immune checkpoint inhibitors are a novel class of monoclonal antibodies that target inhibitory receptors on T cells, other immune cells, and tumor cells. And these drugs have revolutionized oncology because they have been shown to improve mortality across a wide spectrum of malignancies. They include CTLA-4 antagonists like ipilimumab, PD-1 antagonists like nivolumab and pembrolizumab, and other drugs. And this is not even a complete list. So these drugs basically inhibit inhibitory receptors and therefore allow T cells to become activated and to fight the cancer cells. However, there's no free lunch, and these drugs can cause a unique spectrum of autoimmune side effects known as immune-related adverse events that can affect virtually any organ in the body, including the skin, the heart, the brain, the colon, the endocrine system, so thyroid, for example, and of course the kidneys. Now, immune checkpoint inhibitor-associated AKI is usually AIN. AIN is the most common pathological lesion seen in these patients. More than 90% of patients will have AIN. And the clinical presentation is similar to other causes of AIN. So patients will often have pyuria and mild tubular proteinuria. There is frequently extrarenal immune-related adverse events that have either occurred concomitantly with the AKI or have occurred previously. For example, colitis, thyroiditis, rash. So particularly if the patient has had an extrarenal IRAE before, and they're now presenting with AKI, your suspicion for that the AKI is due to the immune checkpoint inhibitor should be raised. One of the more interesting features of this entity is that there can be a delayed onset. So typically with AIN, a patient may start antibiotics, and a few days later, their creatinine may start going up, and you suspect it may be the antibiotic. In this case, we can see AKI that even several months later, and the treatment is steroids. And in the vast majority of patients, steroids seem to work well. Question 2. A 66-year-old man, previously healthy, is admitted to the hospital with chest pain. Vital signs on admission: blood pressure 126/78, heart rate 102, respiratory rate 20. ECG reveals ST segment elevation in leads 2, 3, and AVF. He is treated with aspirin, unfractionated heparin, metoprolol, and nitroglycerin, and then taken to the cath lab, where he undergoes successful PCI of an occluded right circumflex artery. During the procedure, the BP remained above 120/70, and he remained hemodynamically stable thereafter. The serum creatinine was 0.7 on admission, went up to 1.4 on hospital day 3, and it was 7.8 by hospital day 9. Skin examination was notable for livedo reticularis. The part of the kidneys most likely involved in the pathophysiology of his AKI are A, afferent arterioles and glomeruli, B, efferent arterioles, C, acute tubular interstitial nephritis, D, tubules, E, interstitium. Sorry, I think there's a typo there. There's choice C. So most people got the correct answer, A, afferent arterioles and glomeruli. This patient's presentation is consistent with renal atheroemboli. Angiography is the most common triggering event. It can also be seen with therapeutic anticoagulation. The clinical course is variable. So some patients can have subacute kidney injury, which occurs several weeks later. But it can also present with more rapid and severe AKI occurring earlier, as was seen in this case. So it can be a tricky diagnosis to make. In this case, the physical exam findings of livedo reticularis was the giveaway. Patients can also have blue toes. Urinary findings are non-specific. There are some blood tests, though, that can be a hint, including eosinophilia and hypocomplementemia. The pathophysiology is that cholesterol crystals are lodged in the small arteries, including the afferent arterioles and the glomeruli, and the treatment is largely just supportive. And that's it. Thank you for your attention, and I'd be happy to take any questions.
Thank you very much, David. Can you hear me?
Yes.
Great. That was a great talk. So there are a few questions which I wanted to ask from the audience. There's a group of questions really related to management of AKI and heart failure. So let's just quickly start with that. What's the role of diuretics in heart failure? And if you see the creatinine that bumps in a patient treated with a diuretic agent, what's your management? When do you stop or back off on diuretics? What is your general approach there?
Yeah, that's a great question. Well, so first of all, you have to pick what type of diuretic are you going to use. You're going to use a loop diuretic or a thiazide diuretic, and typically we want to use a loop diuretic. They're more potent. We could talk about the dose or giving a diuretic as a drip versus bolus dosing. There was a New England Journal paper several years ago called the DOSE trial, which compared high dose versus low dose and drip versus bolus. Bottom line was that drip versus bolus didn't seem to make much difference. High dose versus low dose, I believe the high dose, you got a little bit more urine output with the high dose, but heart outcomes were not significantly different. My personal preference is in the ICU. I tend to use a drip just because it's more easily titratable. As far as creatinine, so as I mentioned, to a certain extent, the creatinine will go up with effective diuresis simply as a result of hemoconcentration. So I would not back off because of that. I do tend to hold ACE and ARBs in the setting of diuretics. And of course, you don't want to give NSAIDs or any other nephrotoxins. But you have to prioritize the patient's breathing.
Great. And what workup do you think should be done if a primary care doc sees someone with acute kidney injury in the outpatient setting, but the patient isn't sick enough to be hospitalized? What sort of workup do you normally recommend for those type of patients? Sure.
Real quick, I review their medications, particularly NSAIDs, particularly recent changes in their ACE or ARBs. I asked them about volume depletion. So have they been febrile, diarrhea? Are they peeing okay? Are they making good urine? If not, they may need an urgent renal ultrasound to rule out obstruction. And I'll usually check a urinalysis, make sure there's no blood or protein that might raise my suspicion for other things like glomerulonephritis or AIN.
Do you routinely do a renal ultrasound?
No, only if I'm suspecting obstruction. If the patient has a history of BPH, and now they're saying that they're waking, usually they wake up twice a night to urinate, and now they're waking up 5 times a night to urinate, and they're not fully emptying their bladder. That's the kind of patient that I would get a renal ultrasound on.
Great. Thank you. And I know there are many more questions. I'm going to look at those questions and add them to the list for the Q&A session at the very end of the nephrology section. So thank you, David. Really appreciate it.